Hi everyone, in today's video we're going to take a quick look at the adult bradycardia algorithm. Now the first thing you're going to notice is that some numbers have changed.
We fear change.
We've all been taught from day one that bradycardia meant a heart rate less than 60. Okay, now we look at this algorithm and it says 50. Wow, how'd that change? The AHA recognizes that some people have naturally low occurring heart rates. Like this guy, the very physically fit. He's an athlete. He naturally has a low heart rate. Good for him. He's not calling 911. This guy's calling 911. This guy's heart rate should never be 60. And anyone who's having bradycardia, there's a reason for it. So step one, identify that they're bradycardic. They have a low heart rate. Two, why? Why are they having a low heart rate? If you go over to the side of the algorithm, you'll see the list of H's and T's. That's our culprit. We got to find out why this person has a low heart rate. Moving on through the algorithm, we're going to start our supportive care. Oxygen, gain vascular access, get a 12-lead EKG if you can. Next, is the patient hemodynamically unstable? Are they having signs of shock, low blood pressure, ischemic chest pain? If they're not, well, then you're just going to watch them. If they have no symptoms, not sure why they call 911, but you're going to watch them.
I'll be watching you.
If they are, the treatment immediately is to get that heart rate up. Now, let's go back to that list of H's and T's. Regardless of why the patient is bradycardic, our initial treatment is the same. It's going to be Atropine. 0.5 milligrams IV push. Atropine sulfate, 0.5 milligrams IV push. Repeat doses, 0.5 up to a total of 3 milligrams. Therefore, while we're trying to figure out why the guy is bradycardic, we're going to treat it with Atropine while we're figuring out what the problem is. Make sense? Now, if Atropine doesn't work, we have some other strategies. One, transcutaneous pacing. We have a couple of other drug options. Not first-line drug options, but they can be used if Atropine and pacing are ineffective. We can use dopamine to increase the heart rate. Dopamine, the dose, 2 to 10 micrograms per kilogram per minute. That's dopamine. We can also try an epinephrine infusion. The dose there, 2 to 10 mics per minute, not weight-based. Now, as you're going through your list of H's and T's and trying to figure out why your patient's bradycardic, one of the first things you want to look at is this patient having an MI? Get a 12-lead. It is not uncommon to have bradycardia associated with an inferior wall MI. Here's why. The right coronary artery that comes down and supplies the inferior wall of the heart also supplies the SA node. So, if you're having an ischemic attack of the right coronary artery and having an inferior wall MI, it is not uncommon to see bradycardia associated with an inferior wall MI. Now, here's the rub. You can't fix that. Sure, we can give them atropine and get their rate up a little bit, but this patient needs to go to the Cath lab, which means we need to alert the ER quickly, which means we need to get that 12 lead right away. So if the patient is symptomatic, bradycardic, you gave them atropine, it brought their rate up, they recovered a little bit, get a 12 lead. Make sure this patient's not having an MI. If they are, get the ball rolling, get that patient to the Cath lab, because that's where the fix is. I'm Mark, thanks for watching. We'll see you in the next video.